Welcome to The Deep Dive. We take that stack of sources you give us, pull out the essentials, and, well, get you up to speed fast. Today, we're looking at AI in healthcare. It's really making that jump, isn't it? From just promise to, actual clinical use. And if you just look at the money, it tells a story. The global market, it's exploding, something like $27 billion this year, give or take.
Yeah, right.
And sources say it could blast past $208 billion by 2030.
That's huge.
It's a compound annual growth rate near 40%, so nearly 10 times bigger in just 6 years.
Wow.
Right now, machine learning, software solutions, that's where the big money is flowing. So the chat isn't just about efficiency anymore. It's specific, real breakthroughs happening in clinics.
Exactly. And what's really fascinating now is how AI is shifting.
Mm-hmm.
It's moving past just static diagnosis.
Mm-hmm.
Things like, helping radiologists read scans, which is great, very powerful, but still kind of reactive.
Okay.
Now it's moving into dynamic prognostication. It's not just seeing what's there now. It's trying to predict what happens next with the disease.
Right. Anticipating the future. And I guess oncology is where we see that really clearly.
Absolutely. Some of the most compelling work is with liquid biopsies. AI analyzing those tiny bits of circulating tumor DNA, ctDNA.
And the lead time there is, what are we talking?
We're talking a critical 5 to 7 months lead time.
5 to 7 months before a relapse even shows up on a normal scan.
That's right. For things like non-small cell lung cancer, colorectal cancer, that kind of lead time, it completely changes the game for intervention.
Totally redefines it.
But it's not just clinical speed. It's also hitting R&D, drug development. Look at in silico medicine's drug candidate, rentosertib. It's for IPF, idiopathic pulmonary fibrosis, a really nasty lung disease.
Okay, rentosertib. What's the big deal with that one?
Well, it's a landmark, really. It's one of the first times where modern generative AI found the biological target and designed the drug molecule.
Both, the target and the drug.
Both discovered and designed using AI. And it's not just theoretical. It's now in phase 2A trials. So AI isn't just tweaking things. It's genuinely creating new therapies from the ground up.
That's incredible speed on the R&D side. How does that sort of efficiency show up day to day for doctors, nurses on the front lines?
Yeah, good question. It translates very directly through generative AI tools like ambient scribes, the biggest headache-driving burnout, documentation that pajama time charting doctors do late at night.
Nightmare.
Well, these Gen AI scribes listen in during a patient visit and draft the clinical notes automatically.
Does it actually save time?
The data is pretty clear. Clinicians using these, they spend about 20% less time on notes per appointment.
20%? That's significant.
That's not just a number. That's giving doctors back their evenings, their weekends. It's huge for burnout.
Okay, but connecting this all together, all this great stuff, predicting cancer, cutting down paperwork, it all bumps up against this issue of bias, right? AI is only as good or as fair as the data we feed it.
This is the crucial point. It's the big gating factor. We saw that real-world example, didn't we? An AI system ended up prioritizing healthier white patients over sicker black patients for extra care management.
Right. I remember reading about that. How did that happen?
And you have to understand why. It wasn't, explicitly programmed to be biased. The model was trained using historical cost data. Past healthcare spending was used as a proxy for who needed care most.
Wait, cost data, not clinical need.
Exactly. Cost data. So it basically learned and amplified existing inequities in who got care because it was optimizing for a financial number, not a health outcome.
That really brings up the whole accountability question, doesn't it?
It does.
AI just reflects and scales up our own biases. So we absolutely need these clear frameworks focusing on things like validity, fairness, security, making sure it's explainable.
We have to tackle those systemic risks before we even worry about the tech breaking.
So wrapping this up, what's the takeaway here? What does the future look like?
Well, the reality is augmentation, not replacement. We need AI-literate professionals, nurses, radiologists, doctors who can supervise these tools, integrate the outputs, but still apply their human judgment, especially for complex cases and ensuring equity.
Right. Human oversight is key.
Absolutely.
So the main hurdle now isn't really the tech risk anymore. Is this AI accurate? It's shifting, isn't it?
It's shifting hard toward governance risk. Is it trustworthy? Is it equitable? Who's liable when things go wrong?
Okay, so here's the final thought then. If AI bias often comes from using financial data, like cost, instead of actual clinical need, what other non-clinical metrics are currently driving decisions in healthcare operations? Things we maybe haven't even thought about that we should probably audit right now before we hand them over to an algorithm.
That's the million-dollar question, maybe the billion-dollar question, facing healthcare leaders today.